to cover a little bit about each of the medications, and these are my disclosures. I am in the steering committee, so that's scientific consulting for several clinical trials that I'm going to show you today. I also get research funding to the university for several of the clinical trials I'm going to show you. And also, this is really new for the last 2 years that I'm going to say I will discuss some off-label medications. Up to 2012, I would used to say all that I'm going to present is going to be off-label. So now we moved a little bit farther away, and this is gorgeous Portland. And for some of you that we didn't see, you should go and see it. So this is really a continuation of what Dr. Azad showed you earlier. We have to think for the patients of the significant burden and not just about numbers. Though for clinical trials, I'm going to show you a lot of numbers. So Cushing's disease, because of the late diagnosis, but also about the pathophysiology of cortisol excess, has a lot of comorbidities that we have to think about. Metabolic syndrome, opportunistic infection when it's diagnosed late, diabetes, vascular disease, cognitive impairment, and impaired health quality of life that usually we don't have time to think about in a 10-minute appointment that we have with the patients, but it's getting very important, and of course some other comorbidities that you all know. So this is what we have to think about when we treat the patient. And also we know that if we treat them earlier, some of the comorbidities can be reversed, and if we don't, then the mortality is going to be increased, and I don't have time to show you today. There are several very large studies showing that not treated Cushing's is increasing mortality up to 4 times than normal, and furthermore, there are some studies showing that if you treat them properly, and now we can spend 2 hours just talking about how to treat and what properly means, then the mortality is going to be reversed to normal, and that UK study is really wonderful. So what are our goals? If you look at it, they're pretty similar with what you have seen for acromegaly. So we are endocrinologists, and I know most of you are not in this room, but we look at numbers. So we want to see normalization of markers, and then we sit in consensus meeting and talk about for hours and days what a normal means. So we want normal numbers with minimal morbidity. We also want to look, and this is happening more and more, to try to reverse the clinical feature. And of course, if we can, we want also long-term control without recurrence, and this we didn't move at all into that. So I have to say, and it pains me to say that, but transsphenoidal surgery is the first line for Cushing's disease. Though, if the patient fails surgery, and that depends, and we're not going to talk about the surgeon that we choose, then after that, we have several therapies, and the paradigm for treatment after that is changing a little bit. And also, I didn't say in the disclosure that I'm the chair of the Endocrine Society Committee guidelines, so I'm going to probably be biased in that area too. So repeat surgery is a possibility, and we have relatively good rates, but still it's 50% cure rate with second surgery in the hands of best surgeons. So we have to think about medical therapy. I'm going to talk all my talk after that. Bilateral adrenalectomy, I think it's moving with small exceptions towards the end of the paradigm. And radiation, we can talk about, but you're going to have it covered separately. What's the role of it? So which patients should we consider for medical therapy? And I think we need way more data so we can clearly say this patient is a good candidate or not, and we don't even have the biomarkers of the tumor that would be ideal to have. And I think in acromegaly we have way more data. This is sparsely, as Dr. Azad said. I think it's not going to respond to therapy, maybe second surgery or debulking or something is going to be better. We don't have it for Cushing. So if the patient has severe comorbidities and it's a high surgical risk, I usually treat them initially with medical therapy. While awaiting effects of radiation, though I'm not using radiation immediately after surgery, but in some patients that they are coming after radiation, definitely. What should we do now that we have medication available if the adenoma is clearly in the cavernous sinus, or we don't see even a tumor on an MRI? Usually with no tumor on the MRI, with a good surgeon, sometimes they can find a tumor with relatively low risk of panhypopit, but this is debatable too. So we know that the patient failed surgery. What medical therapy do we have available? And we have 3 groups. So I have to say Cushing's is even more developed than acromegaly because we also can block the adrenal steroidogenesis. So we have medications that are working at the pituitary level. We have medications that are blocking the adrenal secretion. And we also have a glucocorticoid receptor blocker. So let's talk briefly about neuromodulators of ACTH release. So trying to decrease the ACTH potentially can decrease the cortisol, and why this is happening is, as you can see here, we knew that the growth hormone secreting tumors have receptors for a while, but more recently, the ACTH secreting adenoma cells have been found, and now that depends how it defined recent, to have a lot of somatostatin receptor type 5 and also dopamine receptor. Talking about dopamine receptor, I'm not going to show you all the data because we have one prospective study. And if we're looking here, I want you to just look, and in colors, these are patients with long-term response, and in green are non-responders. So this is a combination of retrospective study coming from Brazil and Canada again. And if you're looking, the doses that have been used were pretty high. So this is not the dose we're using for prolactinomas. If you're using it for Cushing's, though it's off-label, and I'm sometimes using it in combination, the doses are much, much higher. So could be potential valvular heart disease that we know now for prolactinoma, it's not an issue. But I want you to see that what happened is some patients respond and they stayed responder long term, and some did not respond at all. So we go back to, yes, some markers would be good to see which patients we should use, and we do not have any markers. Furthermore, you all know pasireotide is a new type of somatostatin receptor ligand that, comparing with the others, it's not as good as somatostatin, nothing is as good as the hypothalamus, but it's getting closer. And the somatostatin receptor type 5 that's predominant in ACTH secreting tumor is acting at. It has been FDA approved in 2012 under the name of Signifor, and this is the sub-Q BID. So this is the only one that's approved. If you're hearing about pasireotide LAR that has been approved for acromegaly, this is not approved for Cushing, so it's still in clinical trials for Cushing's, and it's going to be a while until we have any data from that. The large study was a multi-center international study that was finished a while ago. Now we still have some patients in the extension of the extension of the extension. And the doses have been used in randomized, the same dose that they have been approved. And if you're looking at normalization, the rates were pretty low. And I'm going to show you some data where which patients would work more. And the safety overall was similar to other somatostatin analogs, with the exception of hyperglycemia. So most of the effect adverse we knew because we used this type of drugs in acromegaly for a while. Talking about hyperglycemia, of the baseline normoglycemic patients, 43% became pre-diabetic and 34% became diabetic, and I'm going to show you a little bit. Now we know why, and studies are done to see how to treat that. So I said I will come back and say which patient responded more. So if you're looking at the values, these are urinary free cortisol here, and these are overall controlled, and in blue you have different doses. So if the Cushing's was mild to begin with, the patients responded at the higher dose in a much higher number. So for this study it was 50%. And furthermore, when we look back at the data, it's important that you can figure out relatively soon if the patient is responding or not. So the patients that have not responded at 2 months, they were unlikely to respond at 6 months or furthermore. So that again goes back to, it would be really good to know from the beginning, and I'm all for it, and in acromegaly sometimes we know, for Cushing's we don't. So you can try, and then in several months we can figure out. The idea is, would be good to know even before, but if the patient is not responding at all, it's no point to be a year on the treatment and then find out it's not responding. The clinical improvements, they have been clearly decreases in systolic blood pressure and diastolic blood pressure, and I'm going to show you in the same color. So you're going to see the urine is in blue, so it's going to be easier to follow. And the same thing for weight and quality of life, though this was not placebo controlled. So as for every study, you have to think about that the patient is coming and say, yeah, I might feel better because I'm in the study. The data for tumor shrinkage, overall for the study, there were not enough tumors to look at to actually get the significant results. But if you're looking at some patients, and this is one of them, have seen significant shrinkage. I have to say this patient is from Europe, has been treated medically with no surgery. That usually we don't do this in US. And as you can see, in 6 months, despite decrease in UFC but no normalization, the tumor shrank significantly and the shrinkage persisted at 12 months. What's the mechanism for hyperglycemia? The pasireotide inhibits the secretion of insulin, so it's not influencing the insulin resistance. That's separately, unfortunately, the Cushing's patients have insulin resistance to begin with. And also it's inhibiting the release of GLP-1 and GIP. So let's move on, and I would be happy to answer a question on my way to the airport. No, I can stay several minutes after that. Let's talk about what do we have available to block the cortisol secretion. So yes, Cushing's, it's high ACTH, Cushing's disease, but we can block cortisol and potentially we can treat the patients. None of these drugs are FDA approved. Several of them were using off-label, and several of them, and I'm not going to show you all of them, were using them in clinical trials. So what we have right now, ketoconazole, has rapid action. Keep in mind it's off-label. And also, it's very interesting that the FDA has a warning on it for increased liver function. And it's interesting that the European agency had the same warning in the same time with FDA last year. And then, if you ask me, it's probably because of the cost. The European agency reversed completely several months ago, and now they actually approved ketoconazole to be used for Cushing's with no studies. That, again, I think this was really related to cost, but we're waiting for more data. Very important, a lot of patients had gastric bypass, and 30% of our patients are on PPIs. Unless you have gastric acidity, you are not going to get absorption. Metirapone is rarely used in US. There have been, none of them are approved in pregnancy, of course. There have been very few cases that metirapone has been used in pregnancy. And I said I will go back to when I think bilateral adrenalectomy is a good option for a woman that's planning pregnancy. I still think with everything that's going on, then that's rarely you're going to see me that the patient says, I said that they need surgery. This is probably one of the cases. Mitoten is beneficial in adrenal cancer, has a lot of adverse effects. So it has been used for Cushing's disease in France, but otherwise it's not really well tolerated, and I don't know why the French tolerate them. And etomidate is the only one that's available intravenous, and I'm not on the favor list for ICU because sometimes I put patients in to control directly their cortisol. It works really well for patients with severe hypercortisolism that they can't tolerate PO medication. We have a phase 3, and that's all I can tell you about, clinical trial going on with a new type of ketoconazole, levoketoconazole, and I'm going to show you the only public information available, that the differences between effects on cortisol, inhibition on several of the enzymes targets, and also on the liver enzyme elevation, the differences between enantiomers are significant, but we're waiting for clinical data. And this is a large, again, international study, so it might be a year or 2 years until we see even preliminary data. Looking forward to actually see it. How about another type of drug? And you have seen some of the initial data has been published. It's LCI 699. And if you're looking where it works at blocking the secretion of cortisol, but it also works at the blocking of the aldosterone secretion, and this is how has been discovered. So this is a drug that worked for hypertension in clinical trials, and then they saw, oh, it's decreasing the cortisol too, can be used for Cushing's. So, of course, some of the precursor will increase as all for the adrenal steroidogenesis inhibitor, but I didn't show you. So this is a paper that we published last year. This is a proof of concept. There were 12 patients in few centers all over the world. And if you're looking, all patients decreased to normal at least once throughout the study, but that was a shorter, there were 12 patients, and that was a very short study. The longer study has been presented, and the paper is in the works, and you're going to hopefully see it soon. So let's move on, because I want to stay on time and talk about glucocorticoid receptor blocker. And this has been approved in US. It's still not approved in Europe. And as you know, this is a glucocorticoid receptor antagonist at higher doses, and also a potent antiprogestin activity, so it's clearly contraindicated in pregnancy or in women that are contemplating pregnancy, because this will induce abortion. So I usually ask them initially. Now there are several case reports, and we had 50 patients, and I'm going to show you in the prospective study. And there are several other case reports that have been presented at ENDO, for example, but I didn't see the data published yet. And the doses, as you know, are between 300 and 1200. So out of the 50 patients, just 43 had Cushing's disease, and all these patients had failed multimodality therapy. So if you're looking, I'm not going to show you all the metabolic data because the curves look the same. This is the A1C. If you're looking from baseline towards week 16, but the results for OGTT were already normal at week 2, it was a clear, significant improvement despite decrease in some doses of medications that the patients have been on. Looking more at the data of clinical improvement, again, we think more and more that separately from numbers, maybe we should look at something else. For this type of drug, we definitely should look at something else because cortisol cannot be used as a marker. There have been 4 significant predictors for clinical improvement. And the colors, you should look at red. So if you're looking, the number of patients decreased, but over time, we saw more and more red. Weight changes, diastolic blood pressure, 2-hour OGTT, and Cushingoid appearance have been the significant predictors for all these changes. How about long-term use? Once you block the cortisol, the ACTH is going to go up. So you can't use cortisol as a marker, and you can't use ACTH as a marker either. So we looked at the ACTH increases to see if they will stay high and what's going to happen. So if you're looking, this is mean ACTH, and this we recently published. The ACTH goes up, and then off treatment, this was the main study, goes almost back where it started with really huge variations. And I would be happy to talk to you about. And then this is the extension. Some of the variations here you see before, due to the numbers, that the more time they were on the study, the number of patients dropped, and that's happening. So overall, the ACTH levels increased in 72% of patients. If you ask me which patients they increased, were any predictors, the answer is I look for 6 months, and the answer is no. We know that increases occur within first few weeks, as you can see immediately, and then they stay relatively stable. And furthermore, we think that when you block the glucocorticoid receptor, corticotroph tumor progression, exactly what we thought for Nelson syndrome, can happen. If you're looking at the data for non-visible tumor, there were 19, and you expect because this is Cushing disease. For microadenoma, 1 tumor regressed, and for macroadenoma, out of 7 tumors, 1 regressed, and this patient had radiation, and 3 of them were stable over time, and 3 progressed, but one of the tumors that progressed was a very aggressive tumor that once the patient was off the drug was actually an ACTH carcinoma. So overall, we did not have enough patients to say, did the radiation play a role? No. Which tumor are going to grow? No. So the only thing I can tell you right now is if it's a macroadenoma, like for every type of tumor or Cushing's, any type of treatment, we need follow-up imaging to see exactly what's going on, and they need close follow-up. So the safety profile, a lot of patients experience nausea, fatigue, and headache, and the hypokalemia that you expect. So I'm not going to go over all the adverse events, but the hypokalemia can be significant by the mechanism of the drug. Cortisol gets blocked, it's increased so high, so has spillover on the aldosterone receptor. So when you're using it, think about almost hyperaldo effect. And adrenal insufficiency per se was uncommonly reported, but some patients have been treated with steroids. And of course, due to the progesterone effects, you know what to expect, endometrial thickening. So we also have combinations. So if we're looking, there are several of them, of course none approved because not even the drugs. So I'm just going to show you so you have a flare of what is up there, and when you'll see the N, you'll see it's really low. And when I'm presenting this data at the university, I tell both the diabetes and the osteoporosis specialists around that they should really look at the numbers differently, because when they see 12 patients, they're like, yeah, this was really a study. So we have case reports, and if you combine the medication, you achieve additional response. Still, we're not at 100%. This is the only study available with 3 medications, and now it has been a while since this has been published. And if you're looking, the patients have been started on pasireotide. If they didn't respond, the cabergoline was added, and if they didn't respond, in red you have also the ketoconazole, and they did pretty well overall. Other type of combination, just 4 patients have been on Cushing's disease. I have not been using these 3 drugs. I have been using 2 of them in the same time for severe hypercortisolism. And I think that the GI effects are about the same. I'm still concerned about the liver activities, though these 4 patients did well, but I want to see more. But you can see, everybody decreased. So you can block a little bit. Now for how long, that's another issue. And also for very aggressive tumors, not for Cushing's per se. There have been several cases reported of Cushing's disease. If you're looking, this is one of our patients such as post 5 surgeries and radiation. And look at the effect just after 10 weeks of Temodar. But going back to comorbidities, we fixed the tumor in this patient, but then several months later, he died after cabbage for heart attack. So yeah, we fixed the tumor, but the fact that he had Cushing's so long before he was even diagnosed changed the history. So another study that we're undergoing right now, it's a combination study, the combination between pasireotide and cabergoline. As I showed you the data, that we might see additional results, and it's going to be a stepwise, so hopefully we find out which doses and when to intervene. As Dr. Azad said before, maybe we should start thinking of combination earlier before we see all the others failing. So in conclusion, we know that if we intervene early, hopefully with the diagnosis too, but at least after the diagnosis, can restore morbidity and mortality. That management still remains the challenge, and that's good because I still have a job. Combination treatments have emerged, and medical therapy plays a role, and I hope that almost every patient has at least a chance of getting the medical therapy before they get bilateral adelectomy, just because the rate of corticotroph tumor progression is about 40% over time. Which drug to choose is really hard. So don't ask me which one to do it. That depends on patient characteristics, severity of cortisol excess, how the drug works, and where you are in the country, and what about the cost, and I'm not going to talk about that. So thank you.